Thank you. So as I continue to Dr. Dinsha introducing the new kid on the block, I thought I'll show you a case which I did using the same instrument. So I had a patient, 20-year-old college student, plays recreational football. He came to me presenting with a 3-month-old injury of rotational instability with the Lachman's 2+ and tenderness in the lateral and posterolateral area. So that's the MRI scan. So one second. That's supposed to be. Can you put it on the presenter? Take it on the presenter. Is it moving? Yes. So you can see the sagittal MRI scans, and as you can see, you got a deficiency in the as a radial component, and as it goes closer to the intercondylar notch, you can see there is a flap, and then you can see it's an ACL deficient knee, and the medial side, that's a PCL coming into view, and nothing on the medial side. So again, looking at the coronal images, going from front to back, you can see there's edema on the lateral aspect of the femoral condyle. You can see the complexity of the tear across the body, across the hiatus, and a flap component closer to the lateral femoral condyle. So that's a cross section of the at the meniscal level, and you can see there is a radial tear, and the arthroscopy will reveal the rest of it. So this is the view, and you can see that there is a large flap of the posterior horn extending into the root, and you can see that the tear extends across. When you probe it, you can see this is a loose flap out there. You can't definitely call it a root, it's more of a posterior horn extending to the root, and so as I was probing it, I found that it's just not a flap there, it is extending into the meniscocapsular area as well as the wrap, and there is a kind of a intermittent flap adjacent to the one in the lateral aspect of the hiatus as well. So what we do, in most instances we would use suturing as you would do with the radial tear. So here I've used the new device, the Novostitch Pro. So my first aim was to reduce the meniscus down and without causing any damage to it, whereas all the other suture passes like the Scorpion or the TruePass Mini, FastPass Mini, you have to kind of grab the meniscus, so you don't have to do that here. So you can see how the jaw can kind of go beyond the condyle and you can retract it up, so you can visualize what's happening on the other side. And then the lower jaw kind of passes through underneath, and so I take my first bite across onto the meniscocapsular area. This is probably the kind of the ramp variant on the lateral side, which Dr. Dinsha was trying to describe earlier on, where the ligament of Rissler comes across. And then you take a second bite onto the flap. And again, you can see how easily it can be maneuvered across the flap. You don't have any risk of damage to the femoral condyle surfaces, as the needle just diverges tangentially across the upper jaw. So once you've taken the sutures through into through the portal, you can then slowly bring the loop down. Then you can reduce the flap back onto the meniscocapsular area. You can throw your sliding knots down. So this can also act like a ripstop mechanism as well. So when you put sutures across, you've got one that's stable onto the meniscocapsular part of the meniscus. So you have to do it in a controlled fashion. You don't want these sutures to kind of rip through the meniscal tissue or the capsular tissue. So keep visualizing in the back, making sure that it's reduced. Not a lot of force is required, and it's a 2-0 ultralight that's being used in this. So then you cut your knots. Now that you've got that flap under control, so you reassess your rest of the tears now, see how well they reduce. So it's like kind of, it tries to wedge between, the tear tries to wedge in between. So you can see there is some meniscal tissue just anterior to the hiatus there. So we'd like to stabilize it further across there. So the next stitch would be to hold on to that meniscal tissue and onto the flap. So that's what I'm trying to do here. So again, try to go as far posterior onto the meniscal capsular tissue. So I go oblique across to the previous stitch that I put, so that I get a better hold on that. Again, the same routine, you pull the sutures through. And again, you don't want to do it too fast. You want to do it in a very controlled fashion so that the sutures move in a smooth fashion without causing any damage in those areas. Because we don't know, there could be others, slight longitudinal tears across, and when you tug too much, it can just cut through. So once that's been tied down, then what's left is to connect So you can see that how it goes, crisscrosses across. So each time I put a suture across, you reassess what's remaining, especially in complex tears. As you reduce and repair parts of it, you need to reassess whether how you're going to approach the next. So you can see that that's now really stable. So all we need to do is connect the remaining tear as a radial tear. So this time I view from the anteromedial portal and I bring the instrument from the anterolateral. So I'm trying to take a bite as far lateral as possible at the hiatal region. And again, you can see there is no risk of any damage to the femoral condyle surface because the needle just goes tangentially across the upper jaw. So you maneuver over the remnant flap. And try to take a bite as thick as possible without causing any further disruption to that meniscal edge. And again, the same routine follows. You pull the sutures in a very slow, controlled fashion. And then you tie the knot down. So then you have these small remnant flaps, so you can use your meniscal instruments and tidy up the free edges, or use shavers in a controlled fashion. So that's how the final construct looks like. So if there's anything loose flaps across the, where you feel it's unstable, I just tend to trim it down. So the take-home message is we all need to, as the newer technologies evolve, we need to adopt it and use it to your advantage. Of course, like Dr. Reenshaw said, it's cost prohibitive at the moment. So when it comes down, it will be much more user-friendly for us in terms of the patients. Thank you.